शुभं करिष्यामि सिद्धिर्भवतु मे सदा पद्मपत्रविशालाक्षी पद्मकेसरवर्णिनी नित्यं पद्मालयां देवी सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Good evening, everyone. I am Dr. Richa Kothari, and I welcome you to our last session of CT Physics. We've already finished our MRI Physics series, and this is the last lecture of our CT Physics. Today's topic will be Advanced CT Physics and Radiation Protection. Dr. Nilay Nimbalkar will be the speaker for the session, and Dr. Hemant Telkar is our moderator. Dr. Nilay, as we know, he is the director of Precision Scan Center in Nagpur, and he's a very active member of IACI. Dr. Telkar is the president of our IACI, and he has his own center, Infinity, in Mumbai. I welcome you all for our last session today. And over to you, Dr. Nilay, for the webinar. Thank you.
Hi, thank you, Richa. I will just share my screen. Hello, can you hear me? Hi, Pudyavan, Richa.
Yeah, I can hear you.
Yeah. And is my screen visible now?
Yeah, yes.
Thank you. So we will start with the second presentation of CT Physics Part 2, which includes some advances, some still the remaining part of the basic physics, and then we will proceed with the radiation protection along with the advances what we are going to cover today. So in the last scans, what we saw is the birth of CT scanner by J.N. Hounsfield, his first images in 1972 with his first generation CT scanner, then moved on to the second generation scanners, then the fourth generation scanner. So the steps were going on. Some has some faults, some has some advantages, and we saw it through the last presentation. The gantry, the tube, the detectors, everybody started improving on all the things. The newer detectors came, the faster tubes and the rotation speeds have improved to give us better image resolution with detectors and the cone beam. This is all possible because of the slip link technology that we have. And then techniques of image reconstructions like simple back projections to filtered back projections. Now we can see more grays and more shades through all the images. And that's what the CT Physics Part 1 was. Now we will go to the Part 2, where we will include the spatial resolution, the temporal resolution, how the table movement is. So in short, we will just touch these points, how quarter shift and moving error technology helped us to improve the spatial resolution. Then we will see small part of angiography, then the cardiac CT, dynamic CT, a part, and we will just touch the spectral CT, which Pudyavan is nicely doing at his center. And then we will talk about radiation dose reduction while doing a CT scan. So whenever we are talking about a resolution of image, we have three main aspects which are really important to us. What are those aspects? And the one is spatial resolution. The second will be contrast resolution. and then the temporal resolution. As we all know, this contrast resolution part is not that great with CT scans. MR definitely has much better contrast resolution than the CT scanner, and even the PET scan is having better than us. What we are talking about, or what we are watching about, is a spatial resolution. Presently, the spatial resolution of CT scanner is far better than few and a bit lesser than few. We will talk about that in the slides to come, and then coming to the temporal resolution. So if we are starting about the spatial resolution, it is the ability of a CT scanner to display separate images of two objects, like one object which is here, another here, and it's the ability of the CT scanner to separate these two images and objects nicely. So if two smaller objects of different densities are placed just near adjacent to one another, how better I can resolve or how better I can see those objects is the spatial resolution. Now it has many complicated things that computed tomography. This response is either called as a point spread function. So 2 points, how they nicely we can isolate one point from another, that is point spread function. So in on axial plane, this is the point spread function, which is the spatial resolution, and on the z-axis, that is along the length of the patient, it is the slice sensitivity profile. The response is often quantified in what do we call is that full width at half maximum, the curve what we call, and we take it at the full width of half maximum point, and that is the FWHM. Another area where we calculate is a modulation transfer function. This would yield useful information on image quality as a function of frequency. However, clinical assessment of this MTF is complicated and not routinely performed by medical physicists. So spatial resolution is limited by acquisition geometry. What geometry we are acquiring and how density differences are there of the CT scanner, and the reconstruction algorithms that we use to construct the slice thickness. The performance of the present CT scanner, if you talk about 64 slice scanner and the above ones, with regard to the spatial resolution, is expressed as full width at the half maximum. Point spread function is at approximately 0.6 to 0.9 millimeters in both X and Y, as well as the third direction, the Z axis. So that's why we can reconstruct our images in axial, coronal, sagittal, as well as in the different oblique planes also, because now we are having spatial resolution of less than 1 millimeter. So how do we improve the spatial resolution, keeping whatever number of detectors are there at the same? So we will just talk about the spatial reconstruction or the resolution by reconstructed images, and that depends on one, size of the detector element. If smaller the detector, better will be the spatial resolution. Along the arc, so smaller detectors along the arc on X and Y planes, or along the Z axis. So if the detector is 1 millimeter, we are going to get the resolution of approximately 1 millimeter, unless and until there are some shutters applied above the detector to reduce the resolution again. So consider that all these detectors are 1 millimeter. So presently we are having 1 millimeter resolution along the XY planes as well as the Z axis planes. So we are getting a better resolution, which is equal in all X, Y, and Z axes to get proper imaging in all the planes possible. Plus, it is the angular separation of the projection of that particular point on the detector. So if we have angular separation or we have smaller detectors, we can have better resolution of the images. So if I want to have a resolution of 1 mm and I have a FOV of say around 400, so just for calculation purpose, the resolution which I required for my image to have is 1 millimeter, and I have a FOV of say around 400. So how many number of detectors I actually need to have along the array to get this FOV and a spatial resolution of 1? So to get that spatial resolution of 1, I have a formula that my FOV and the number of detectors has to be calculated by twice the FOV divided by this reconstructed image का spatial resolution which I want. So if I want a resolution of 1 millimeter, say for 400 FOV multiplied by 2, so 800, and the resolution of spatial resolution which I need is 1 millimeter. So I divide this 800 by 1. So at least 800 detectors has to be there covering this FOV to get me a spatial resolution of 1. So I need so many detectors aligned in the XY axis to get me the proper spatial resolution of a FOV of 400. So if the FOV is less, the number of detectors will be less. But if I need a proper FOV for a large FOV, proper resolution, I need those many number of detectors lined along X, Y, and Z axes. So I can double this resolution by doing one more thing. What are those? One is a quarter shift technology and another is a moving anode technology. So what do you mean by this quarter shift or moving anode technology? So supposedly my tube is here, my detectors are down. So whenever I think every time my detector is passing at one particular point and my tube is here, the resolution for this point I'm getting at one particular detector. And if I reverse it, still the same detector is getting activated for the same point. Now, if I shift my anode by quarter of the shift, so this is called as quarter shift. If I shift it 1/4, so when I completely revolve around this point, so what is going to happen? At 1/4 of shift, when I go exactly 180 degrees down, I'm going to activate another detector which was not initially activated for the same point. So now I am getting two detectors for the same point, hence increasing number of detectors applied for the same point, giving me better spatial resolution. This I can achieve by another way, by angulating the anode for the same particular point and getting two different images or resolution for the particular point by angulating it fast between one and the second place. This again will give for the same detector, one image is for this area and another image for this area. So two areas are getting activated at different point of time by single detector, giving me double the resolution as compared to a single point and single tube and single detector resolution. So this helps us to find better resolution at the space, giving us better spatial resolution without increasing number of detectors. Then coming down to temporal resolution. Now temporal resolution helps in the parts where we need to evaluate organs which are moving continuously. For example, heart, which is moving continuously. So we need to have something which can take image of the heart where it is moving at a particular time. So it's like having a shutter, the faster shutter speed of your camera which you are holding. So if your shutter speed is high, then you can definitely pick particular part of the organ and take a good picture of it. And that's what is temporal resolution is. So temporal resolution is ability to resolve fast moving objects in the displayed CT image. So if I need object that is, for example, heart, if I want to have particular image of that heart and that to be nicely taken, then I need better temporal resolution. So it is to avoid motion artifacts and motion induced blurring of the image. So for a good temporal resolution in the CT, which is the fast data acquisition has to be there. So we need to have fast rotation of the X-ray tube. So presently, if I calculate the X-ray tube rotation speed, it could vary from 270 milliseconds or 330 milliseconds to say 1000 milliseconds. for every rotation which I am doing of 360 degrees, what I am getting is one rotation in say around 0.33 seconds. So for that rotation, if I divide the rotation time by half, that is going to give me the temporal resolution plus the fan angle rotation. So if my tube is rotating at 300 milliseconds, then what temporal resolution I am going to get is around 150 milliseconds ka temporal resolution. So how can I improve that? By making faster and faster CT scan rotations. There is a point in that I cannot reduce or increase my speed for reducing temporal resolution further, because faster my gantry moving, there will be enormous G forces acting on my gantry. So there is a limitation to the speed of the gantry rotation. So what I can do, either I can add another tube and another detector array, that is the double source images. So if I have two tubes, two detector arrays, I'm definitely going to improve my temporal resolution. So that is the dual source CT scan. So the single source, single detector has some limitation, that is the speed of gantry rotation. But if I can add another source and another detector, I can definitely improve my temporal resolution to particular point. So this is a chart where we can compare how the temporal resolutions are varying or the spatial resolution are varying between the different modalities. So for CT scan, presently what spatial resolution we are having is approximately 0.5 or 0.625 millimeters, which is actually the thickness of the detectors what we are using. So 0.625 detectors in a 64 scanner, that one or a 0.5 millimeter is going to give us similar spatial resolution. Then the temporal resolution depending on the gantry rotation speed, which is presently between 83 to 135 milliseconds, which is far less than catheter angiography or even echocardiography. So we need to improve on that part, and there is limitation right now for the speed of rotation, and that's why we can add number of detectors or add another tube, giving rise to better temporal resolution. So this is a comparison where spatial resolution CT is much better than MRI, and for temporal resolution CT is not still nearing the MRI for the category of motion artifact, but for angiography we are improving on that part by improving the dual source image. So why all these things are important? We need to evaluate the moving organ. Another important factor which we missed on the CT physics part 1 was the pitch. So a good machine, now what we are having improvement on the part of rotation, but what we need to improve is the pitch, as we need to have faster scanners for angiography or for dynamic CTs. We want to increase our pitch further and further. So what do you mean by pitch? Pitch is the length of table increment per 36-degree rotation time of the tube for a pencil beam. But once we have helical or MTCT scanners, our beam is not a pencil thin beam. Our beam is right now a cone beam. So it is a cone which is coming down. So we have to modulate our definition of pitch to the divided by width of the collimated X-ray beam rather than just a pencil beam. So for every 360-degree rotation of the collimated beam, how much increment of the table is going on, that is going to define the pitch. So for example, I have an increment of 10 millimeters per rotation and my beam collimation is around 10 millimeter. So I'm getting a pitch of 1, that is 1:1. But if I have a faster increment and still my collimation of the beam is going to be the same, that is 10 millimeter, then I am having a pitch of 1.5. If my increment is less and collimation is same, the pitch is going to be lesser. And if the increment is more and the collimation is still same, the pitch is going to be higher and higher. What are the advantages of having higher pitch? One, we will discuss it while we will be talking about reducing the dose of radiation which we will give to the patient during scanners. And another is the faster scanning techniques. So whenever we need faster scanning techniques, we need higher pitches. And that's why we need all these techniques, because we want to evaluate the structures in a better way. We want to reduce the radiation doses to the body and reduce the contrast injection volumes given to the patient. So for example, this is a CT angiography study where we wanted to include from chest, complete abdomen, and even part of the lower limb in a single injection phase, as well as in a one breath hold. So we need to have faster scanning techniques as well as the proper evaluation in the spatial resolution. So our scanner is fast. We have better spatial resolution of 0.625 in both XY and Z axis. And because we have faster pitch, we can cover the area in lesser contrast injection time to get same CT angiography, which is either possible by injecting more and more amount of contrast and taking longer duration, giving more radiation. Another important aspect which has improved further is the cardiac CT evaluation. So we use the same contrast, but we use faster injection rates. We have faster CT scanners like 64 slice, 128 slice, or say 256 slice plus the flat panel detector CTs. And that's why we are improving on the duration of the scan from say 10 to 12 seconds to 5 to 6 seconds, or even a single breath hold or single RR wave scanning is also possible for complete heart. What do? We do ECG gated acquisitions, and we need proper breath hold. Just for an example, in short, we will discuss it. So now I want to evaluate a heart which is beating fast, and I don't have a proper camera to take it. That is the machine which is not faster enough to acquire the images. So if the pulse is good, breath hold is good, and I'm not having good scanner to evaluate, or vice versa, if I'm having good scanner, but the pulse rate is not that well reduced to a particular level, that is a faster pulse rate and a better scanner, what I'm going to get is a blurred image. If everything is perfect, that is the heart rate is nicely controlled, the breath hold is good, and I am having a better scanner, then I'm going to get a better image. And if there is a problem with the breath hold, I'm going to mix the picture. So this is an example where the heart rate was much faster. Say immediately it should to say 100 and 120 while taking the scan. I am getting blur at the RCA as well as some blur at the LAD. Similarly, if everything is good, what I'm getting is better picture of RCA as well as LAD and rest of the cardiac structures. But as the scan was going on, the patient could not hold his breath and he had a bout of cough during scanning. What I'm going to get is a blurred picture and mix or the missed vessel, and that is going to hamper evaluation of particular cases. So I need everything to be absolutely good breath hold, good heart rate control, and a better machine to get proper images for cardiac evaluation. How do I evaluate or take a cardiac scan? So we have ECG gated images where we take the RR interval and we can reconstruct the images from one RR to another RR. If I divide it into 100, so from 0% to 100%, I can reconstruct image at each and every level. So if I want to have better images for a better heart rate, I can take it in the mid diastole level, which is at the end of the RR interval, say around 65 to 75% to 80%, and I'm going to get better images. But if I'm having higher heart rate, I may opt for something between 35 to 45% recon, but this all data is available to me if I am doing retrospective gating. So what do you mean by retrospective gating? So whenever I am taking a cardiac scan, I am taking scan from one RR to second RR interval at multiple pulses so that I can cover complete heart. So while doing this, what I can do, I can completely take volumetric data from all the RR intervals from 5 to 6 pulses to evaluate heart, and then retrospectively go back to reconstruct images at say 75 or 85 or say 70%. I can have some modulations in the MAs during acquisition of this, where I know that I want better pictures at the 75 or 80% of the RR interval, so that I can increase the MA and reduce the MA in rest of the cardiac phase. So that is a modification which I can still do in retrospective acquisition. Then there is something called as prospective acquisition, where my heart rate is absolutely stable and I know I can acquire better pictures at 70%. What I can do, I can just ask my machine to reconstruct or acquire images at that particular level. By doing that, I am reducing the radiation exposure in proximal as well as the distal part of the RR interval, and hence reducing the radiation significantly and still giving best possible images. But this has a very narrow window of acquisition. And what we need is some shoulder. So we need something proximal, something distal. So we have something which is called as padding. And what that padding means, so I'm sure that at 75% of reconstruction, I'm going to get best images possible. But what if my heart rate from 60 went up to 65, or my heart rate from 60 went down to 55? So that modulation or that change in the ECG is going to hamper my image quality. So what I'm going to give, I'm going to give my machine some leeway, and I'm going to increase my scanning area from say 68 to 83%. Hence, by acquiring a partly wide acquisition and still reducing the radiation dose in rest of the phases. So we have prospective gating, we have retrospective gating, and then we have something which is called as padding. And by doing that, what we are going to get is different images at different phases of RR interval. We can reconstruct at different phases and say which image data is best for evaluation, or we can take some part of evaluation from one part and another from another phase reconstructions, leading to better evaluation of the cardiac structures as well as coronaries. Now we have something which is called as filters or some modifications in acquisition which can detect the misregistration of the vessels, and it can correct it automatically. That is automatic border recognition software, and multiple companies have different softwares where they can recognize that there is some artifact or some step which it can correct automatically, giving rise to better image for that vessel. We are going to evaluate the vessels in multiple planes, at least 2 different angles, and in the curved replanar reconstructions to see the vessels nicely from its origin to the distal part, giving a better evaluation with the help of good temporal resolution, what we can achieve with our machine, and the good spatial resolution. Then we have something called as dynamic city. This dynamic city is having evaluation of some part which is available, and we want to evaluate the dynamics of that part. So we take multiple high pitch scans at particular level just to see how the dynamic is going on. This is a difficogram study which we did for a patient who is severely claustrophobic, and we wanted to evaluate that difficogram study. So we asked him to come to CT scan, gave them perrectal contrast, and did this study to see whether there is any abnormality in the process of defecation. Similar dynamic scans can be used for joints or for the vessel evaluation in inspiratory as well as expiratory phases. The point of interest here is that we have to take multiple scans at particular level, and that's why the radiation dose may go up significantly. But we can use these areas where we cannot go for MRI because of severe claustrophobia, or if there is no other way to evaluate, we can have some bargain with the imaging technique by reducing some doses and still get a dynamic city of particular. The significant improvement in CT has happened on the spectral CT part. In the recent times, spectral CT has given us enormous advantages by giving us a better evaluation of the structures as well as to go to the energy level to get us at the anatomical or the density details of particular part, where we can evaluate the spectral maps and we can evaluate the energy levels of that particular organ. Now we can do the spectral city by doing something which is called a source-based spectral city or a detector-based spectral city. Now, what do you mean by doing a spectral city? So initially we know that we have anode, we have the detectors, or we have the tube and detectors here, and our city tube is ejecting X-rays towards the detectors. Now we assume that the city X-rays what are emitted are having a uniform energy, but which is not true. It has different levels of photons or the X-ray photons which are available and coming through the body to the detectors. Now we can take advantages of this by evaluating different energy levels which are passing through the organ and taking their images with calculations. So once we have those different spectral energies at particular point, it has different attenuation coefficient for particular organ. So at 80 keV, the organ may give a attenuation coefficient or a density of a different value, which will be different if I put a kV of 120 in my X-rays. So we can take help of it by doing two things. One, the source base, that I bombard energies at different two energy levels by a single source. While doing that, I can modify that at a particular point. Only I can bombard those energies, or I can have two different sources bombarding those. So by a single source, like a single tube CT scanner, I can have different energy levels for a particular organ, or we can simultaneously have two sources in a dual tube scanner and to evaluate that organ at different 2 kV levels. We can also have it at detector base. We are using a photon counter detector, which can actually detect energies of the X-rays and evaluate that particular part for that particular energy, or a dual layer energy integrating detectors. What are those? So if I have a dual source, then this is a X-ray tube, this is a detector. At one particular point, I am having X-ray evaluation at 80 kV. Here, the K value is around 120. So now I am having a spectrum of images, which is one at 80 kV, another at say 120 kV. Then I have differences in the attenuation and I can evaluate that. Another example is by kV switching. Like my anode is just wobbling from one point to another, and one point it is giving one particular energy X-rays, and at another point it is giving different energy X-ray, which is passing through the same point, giving me a spectrum of energies for that particular tissue, leading to a spectral city. Then what I can have a single source without switching. So I don't want to switch. It's a complicated technique. So what I can do, for the same part, one rotation is done at one particular kV level, say 80 kV. Then the other rotation will be at say 140 or 120 kV, leading to me different energy attenuations for that particular thing. Then there will be this part where dual layer detectors are there. So one detector is made in such a way that it can detect the lower energies, and the higher energy levels can be detected by the lower detectors. So we have layering of detectors which can detect the photon which are attenuated by one particular energy and then the other particularly, leading to a spectral evaluation of that part of the body. Another thing what I can have is split filters which are placed towards the anode, where energies are split in one particular area as along the z-axis. This area will be of say 80 kV and this will be of 120 kV. And then there will be photon counting detectors which actually counts the photon at particular level and then can calculate energies of those photons passing through to give a higher energy as well as lower energy photon passing through the body and reaching to the detector. So these are different ways by which we can achieve spectral CT scan imaging. Different vendors have different ways, but what we are going to detect by doing all this is spectral images with different KE values. So for same organ, I can have different KV values and leading to different imaging sets for those particular KE values. Then I can have virtually monoenergetic images, like particular images, we can enhance those areas nicely, or a iodine density map, or a particular density map like calcium density map or iodine density map, which will give much emphasis on the areas which are having iodine in it, reducing the rest of the densities, so that I can see this particular area which is containing iodine nicely and depressing or reducing the images or the densities from other areas. Plus, I can have virtual enhanced images or non-enhanced images. So once I have a particular area where the contrast is there, if I have this data, now I can just reduce whatever iodine available to me, reduce it or subtract that part and get an image without iodine map. So this will be a virtual non-enhanced image. So this is virtually non-enhanced images by taking acquisition only once with contrast. So I may not need to take a plane scan and then the contrast scan. What I can do with spectral CT, just takes one single contrast enhanced scan and then reduce all the iodine from the scan to get a virtually non-enhanced image. I can even calculate the effective atomic number and take scans in those particular labels, that thereby giving me areas of different areas of the heart with different atomic numbers which are enhanced in those areas. This leads me to a spectrum of advantages in different areas. What I am going to achieve by doing this. So this is a very good chart from one of the articles. So if I have poor contrast enhancement, I can virtually have a mono energy images for iodine to get better evaluation of the iodinated or the contrast enhanced areas, leading to better evaluation of the contrast or the angiography studies. If I want to reduce the beam hardening artifact, I can have virtually monoenergetic high energy images where all the artifacts coming from the metal is reduced, leading to better evaluation. I can reduce the radiation dose by getting a virtual non-enhanced scan rather than doing the plane as well as the contrast enhanced scans. Or I can reduce the radiation dose in cases where already renal functions are hampered, like in the pre-TAVI evaluation, where predominantly the renal function may be hampered because of the vast disease going throughout the vessels. There I want to reduce the contrast. So what I'm going to do, with lower contrast, I have a mono energy image at low energy, and that will enhance the contrast areas, leading to better evaluation of the angiography. So I have all these parameters by adding to either mono energy level imaging or having a virtual non-enhanced scans. In addition to that, so this is one example where a single scan with contrast is there. This is a plane scan, and if here he got just reducing the iodine map from the same image to get a virtually non-enhanced scan. So this is a proper plane scan and this is virtually non-enhanced scan, and you can see there is hardly any difference, and we can still evaluate the plane scan with a virtually non-enhanced scan also. So that's the beauty of spectral CT, where we can have all these modifications where the contrast is so low, but I can have a mono energy levels of evaluation, and I can still see the evaluation of arch, LVOT, the aorta, as well as the proximal coronary in cases of TAVI. Similar ways, if there is a contrast injection fault or extravasation and I'm having only mild amount of contrast reaching to a particular area, I can enhance it to the iodine maps, and I can enhance those areas by getting to a low energy evaluation at spectral form, take those sets of data and get wonderful images of pulmonary as well as the lower enhanced vessels. This is also useful in abdomen, like evaluating a GB-cal, which is not that nicely seen, and the spectral CT is going to give us better evaluation. Yeah, this is a GB calculus, which is not that well visualized on a plane or a contrast enhanced scan, or in cases where we are not much sure whether the lesion is a malignant one or a benign one, or should we leave the lesion or take cognizance of that lesion, that it could be a contrast enhanced lesion, just sheer the size of the lesion is so small that we can have some partial volume areas there, but spectral CT can give us idea that yes, there is some enhancement in that region, and this could be a small RCC present or evaluating or evolving in that particular part of the kidney. So spectral CT has different advantages, and it's an upcoming technique. It do have advantages in the myocardial perfusion scanning also, and that will give us much better evaluation of perfusion on CT scans in days to come. So in last 3 decades, there is exponential increase in number of CT scans, and that has gone up. That CT is now predominantly approximately 50% of all the radiation which is given to patients by 2010, and it might have increased to 55 or 60% of the radiation which is given to the patients for a medical scanning or X-ray exposures evaluate. So in these years, what we could see that there are multiple articles and multiple in the paper media as well as in the social media that CT radiations are harmful, and multiple many organizations and people are coming up that CT is not good for us. If you compare death rates, definitely there is something which is happening just because of what we are giving the exposure. So it's our duty to reduce the exposure, because we know there are effects happening because of the X-ray exposure or the radiation exposure through everything like CT or the X-ray or the OPG or mammography. So what are these effects? These are called as deterministic effects or the stochastic effects. So whenever we are talking about the deterministic effects means we know at a particular level of exposure, there is going to be something happening like aplastic anemia or myelofibrosis or skin lesions or fibrosis at particular station. But is it possible with the routine CT scans or the X-rays? No. We are not going to give so much of radiation by doing CTs once, twice, thrice, or many times, because in a particular lifetime, we are not going to have so many CTs for one particular patient. So we are definitely not going to cross this mark. So what we are worried about is the stochastic effect or the non-deterministic effect, which can happen at any point of radiation at any point of time. So carcinogenesis is happening at what level of radiation? We don't know. Gene mutation is happening at what level of radiation? We don't know that. Chromosomal abnormality is happening at 1 millisievert, 100 millisieverts, 1000 millisieverts? We don't know yet. And congenital anomalies, in few patients, it may happen at just 1 millisievert, it may happen at 100 millisieverts. So we still don't know yet. So what do we need to do is to avoid and give less and less radiation possible to the patients by improving on our scanning techniques and using newer and newer techniques to reduce the radiation dose to the patient. So we have to follow the ALARA principle and go with it. So how do we measure radiation? So we have CTDI volume, that is at particular volume of the scan. Say I'm doing a scanning, a volumetric scanning. So every rotation, I'm taking one part of the volume. So how much radiation is given to that particular volume multiplied by the length of scan I'm taking. So that is going to give us dose length. So this is DLP and dose length product. And then from this dose length product, if I have some conversion factor for that particular region, so for the chest, for head, for abdomen, there are different conversion factors. If I multiply that, what I'm going to get is the effective dose in millisieverts. So if I have a CTDI volume for this particular volume, if I am doing scan for complete chest, then this, if it is L and this is 3 times the L, what is going to give is the DLP. And if I calculate or multiply it with the conversion factor, I'm going to get a particular dose given to that patient by multiplying that factor. So it is going to give us in millisieverts how much exposure is given to that patient. How can we control this? So we have different techniques. So parameters which are used to do CT are kV. If we reduce the kV, definitely there is going to be reduction in the radiation. If we can reduce MA, there is going to be reduction in the MA. Then if we have faster rotation time, we have faster speed, definitely we are going to reduce the radiation dose. Plus we have something which is external factor like patient centering, patient positioning, where we can definitely reduce the radiation given to the patient by doing proper positioning of the patient. And definitely we have iterative reconstructions where at lower energy level scanning also we can get better images, and we should use all these modifications to reduce the radiation dose given to the patient. How are we going to do that? First, by proper positioning of the patient on the table as well as the gantry table position in the gantry. Then we should have all the machines are now having bow tie filters, and that's why the patient positioning is really important. It has to be in the center so that the thickest part should come to the center of the table so that the radiation will be maximum in that area and will be less in the peripheral areas. Then we have to have a automatic exposure control in our devices or the machines to reduce the radiation doses. So image control parameters, if I have MAS, lower MS is going to reduce my radiation in the same factor as I'm going to reduce my MA. So if the tube current is reduced by half, my radiation dose is also going to be reduced by half. So if my exposure time is reduced, my radiation is going to be lesser and lesser. Now we know that all the body organs are in an elliptical phase, whether it's face, whether it's neck, whether it's thorax or it's abdomen. It's in an elliptical form, some or the other. So whenever I am calculating this, am I going to give the same radiation at a particular part? No, I have to modulate my radiation in axes, not only on the Z, but as well as in the X and Y axis. So if I am scanning a particular area which is thinner, I should have thin or lesser MA. If I am scanning a particular area which has thick parts like shoulder, I must have better MA than the previous one. And as I go towards the denser and denser part, my MA should increase in the same way. So that is automatic exposure control device. It is not only on the Z axis, I want it on the X and the Y axis. Because if my tube is here and I am going to eject my X-rays, I'm going to cover a large and denser part. But if my tube is AP position, the part is not that thick as compared to the lateral position. So my MA and KV can be different than that of the lateral position. So I should be able to modulate my MA in Z, X and Y axis, leading to a 3D model giving to 3D dose modulation on automatic exposure control, which reduces the dose significantly. So proper positioning is also important for KV for reduction in the doses. KV improves the dose of reduction by reducing KV. And like MA, it is not directly proportional. So if I reduce my KV to particular levels, say approximately around 15% reduction in the KV is going to reduce my exposure exponentially. So if I reduce my KV from 140 to 120 KV, then my exposure is reduced by around 30 to 35%. However, the reduction in the KV is just 14 to 15%, but my dose of exposure is going to be reduced by 35%. So we must have better KV modulations while taking the images. Whenever required, we can have lower KV values and still have better images. Now, another advantage in keeping the KV low is that the contrast enhanced images which are taken by taking the CT are definitely because of the iodine which we inject. Now the iodine KEV value will be equal to that of the KEV value of the X-ray which I give when my KV is less. So if I am giving 80 KV, most of the iodine, most of the X-rays will be in the range of KV of iodine, leading to better enhancement of the iodinated contrast, and that leads to better evaluation of the structures when contrast enhanced images are evaluated. So contrast enhanced images are better evaluated with lower KVs for that particular thickness of the body, and hence always the KV has to be modulated depending on the thickness. So this is a chart where we can get better images even at lower KVs because iodine is nicely seen at lower KV values. Another important point is gantry rotation and the pitch. So higher the pitch, lower will be the radiation exposure, and faster the rotation, we can have faster transition of the table, and hence by reducing the radiation dose given to the patient. So that's an X factor which we should always use. Plus the image reconstruction algorithms. Now we have something called as iterative reconstructions. So from the filtered back projections, which has some noise, then we went to further image reconstruction, and now we have something combination of filter back as well as the iterative reconstruction, which can give us better images even at the lower MA and KV acquisitions. So we can have good images with iterative reconstructions, even though there is reduction in the MA, leading to better image quality and reduction in the exposure. So this is an example where without ASA, that is iterative reconstructions, we cannot have better picture at lower KV and MA. But if we have ASA at the same KV and MA, we can have better picture evaluation. So it's our duty that we should always try to get best images and lower the radiation in at particular part where we can have modulations in the KV or even the switching off of the tube while going around or near to the specific organ like thyroid or the orbits or even at the breast, where we can stop exposure at the AP level, and then again the exposure will start from the lateral or the posterior part, hence by reducing the radiation to the particular organ like eye, the thyroid and breast in evaluation of that organ. So this has helped us a lot. So there are hardware advances which has given us better detectors, better modulation in the KV, better modulation in the MA, and hence by reducing the doses. So we should have region-wise protocols like for head, for particular body level, particular height, and particular weight. There can be different protocols, and there will be different protocols for a patient who is thick or at a age of more than 20, and there will be different protocols for the kids, and we have to follow it strictly to reduce the radiation to that patient. So that ends our topic of CT physics advances as well as the radiation dose reduction, and it has really privileged for me that all you people were adhering to it, and ICI is having a good next month, the annual national conference of ICI, and I wish everybody of you will be present there to discuss further the cardiac imaging on CT as well as MRI, and let's hope all we meet in Goa next month for ICI annual conference. Thank you. Thank you, Richa. Thank you, Pudyavan.
Thank you, Dr. Nilay, for your very, even though it's a difficult topic, you made it very simple and interesting. Thank you very much. So just to ask, physics is not everyone's cup of tea. Other than just writing it in the theory exam, how do you think it helps? Do you think it really helps in day-to-day practice, knowing all this physics?
Yeah, definitely, it helps in day-to-day practice. Whenever a child is coming for scanning, we do different protocols. We can modify MA, we can modify KV, and we have to teach it to our technicians as well as our students, because that is an important aspect which they are going to carry forward in their own practice. So if you can teach them now that CT physics is really important and it's helpful in day-to-day practice, it has to be there in your mind. You know it thoroughly, because once you know that lower KV is going to give me a better picture of a calcium, low KV is going to give me better imaging of an iodine in the body, then definitely my student or the person who is doing the scan is going to reduce the KV to particular level to get better images, which he was not doing it prior. Because we have protocols set in our machine, we just copy those protocols, put it on the machine scanner, and start the protocols. So that should not be the point. Every time you see a patient, if you see this is a patient of low weight, I can reduce my KV, I can reduce my AMA, I can use different imaging protocols. Hence, by reducing the radiation exposure to the patient, I must use it.
I agree. We do make our students sit for a few days in the console before we even allow them to report. Because nowadays machines are so advanced and there's so much they can do that you have to know what all you can, how all you can play around with the machine, how you can improve the scan quality, how you can reduce the patient radiation dose. So a lot of things you can do to play around with the machine. I think Udyavan is with us. Udyavan, are you there? He has a dual source. Would you like to add anything to what Nilay said about the dual source CT? He's not there.
Yeah. So, yeah, the main advantage of dual source, especially for cardiac CT, is its superior temporal resolution. So Nilay was eloquently told you what exactly temporal resolution is and how it helps us in getting good quality scans. So in a dual source scanner, there are two tubes and detectors which are mounted at 90 degrees to each other inside the gantry. So when there is a 90-degree rotation of the gantry, that means that each tube rotates 90 degrees each. And within the 90-degree rotation, you are able to get data that is compatible with 180 degrees of rotation of the gantry. So that is how the dual source scanners provide a much superior temporal resolution, because it is able to give you the data of 180 degrees with just a 90-degree rotation, because it has two tubes and detectors. So that basically what it does, it brings down the temporal resolution by half. And especially in cardiac scans, where temporal resolution is the most important factor affecting your image quality, the dual source scanners that's how it's much superior to the other scanners in giving you a better image quality, especially because it has a very good temporal resolution.
Thank you. Again, I would like to reiterate what Dr. Nalai said. We have our annual conference next month in Goa. We have two parallel sessions. One is on advanced cardiac imaging. So that would be good for everyone who's already practicing cardiac imaging. Another is a dedicated workshop for congenital heart disease. If that's a lacune for you, or if it's something you're interested, most welcome. Please visit our website and register. Our physics webinar series end here. We're planning a panel discussion about all the physics topics and artifacts, with usually all the difficulties we face while scanning and how we can improve scan quality. After our annual conference, we'll send you the links. Do join us. Thank you very much for joining us today. And I again thank Dr. Nilay for the wonderful talk. We'll end the session here. Thank you.
Thank you. Thank you, Dr. Richa. Thank you, Pudyavan.
Yeah, thank you, Nilay. Bye, Richa.
Bye.